right along because we're essentially done with that. Well, let me make sure. I wanted to make sure you put same shit, different day, TPA. What's an alternative to TPA? What's another medicine that fits in the same category? Streptokinase. Streptokinase ends in ASE. TPA is actually activase, tissue plasminogen activase. Do not sweat this. This is already in that medication packet I gave you. That medication packet I gave you, I would study the shit out of it. Okay, so I'm going to highlight a lot of different things, but all of this stuff is right in there for you. 100% of all PEs were DVT to start with. We said that already. Now, just what you need to understand is 100% of all pulmonary embolisms started out as a DVT. 10% of all DVTs will guarantee you become a PE. You don't know which one it is. So the number one thing you can do for your patient is get them out of bed within 6 hours. Get them out of bed within 6 hours of major surgery. If they're just really stubborn and you can't, punch them in their throat and get them up, then you're going to have to make sure that they pump their ankles while in bed, that they have sequential compression devices. Your prevention of the DVT prevents the PE. Obviously, it goes without saying that the patient should cough and deep breathe, right? So you get that. All right. Remember your straw. Oh, you know what I would add to your scenario of all this signs and symptoms in terms of respiratory distress? Cyanosis. One of my colleagues, formerly a Tri-C student of mine, now she's we hire only from within. I'm not hiring anybody who doesn't get it. So I hire only from within, and she said she works in the ER at Murder Mount. She stood the patient up because he wanted to use the urinal. She knew enough. She had common sense not to let him go to the bathroom. She said, Shelly, I stood him up to use the urinal. He turned blue. And that was her warning. And he then collapsed on the bed. Thank God he fell back because he could have been walking to the bathroom. And what was it? It was a PE. And he lived because he was right there. Okay, so blue. He turned blue. Just boom. Okay. Now, so that's that. Next on the list, if you look at pulmonary edema, I don't really have to go through this so much as I would have to go through Ards, because as you already know, we talked about it. We said that pulmonary edema was going to be the whole pink frothy sputum, so there's no handout on it. What I would say to you, just for you to have a clue about what could happen, is these are the three patients The 3 C's are the 3 patients who can give you pulmonary edema. Why? Because all of them are swollen. All of them can gain more than 3 pounds in a day. All of them can really have some problems. Now, when we do acute cardio, we're going to do pulmonary edema because it fits more in the cardio patient than it does even these. But suffice it to say, you're going to use a lot of IV Lasix. You knew that. It's edema. Okay? We're going to use some morphine to decrease anxiety and everything else. So it's kind of interesting with pulmonary edema. It's like a heart attack, but it's a lung attack. And so you just do Mona, but you don't need aspirin. So you still do the morphine, you still do the oxygen, you still do the nitro. You add Lasix and Dig. Okay, because really pulmonary edema at the end of the day is a cardiac issue usually. The heart is not strong enough. Okay, but we do care a lot about Ards. So let's do Ards, because Ards is a big deal. Pulmonary edema is on acute cardio. You have a handout on Ards right in your packet. And you already know a little teeny tiny hookup on it. For instance, you know to write down on the handout that it's a mismatch. It's a VQ mismatch. You already know to write that down on the Ards handout. It's a mismatch. The mismatch is on ventilation because the alveoli have collapsed. All phones should be in the bin. Why is it a phone in here? You guys put your phones in the bin? Okay. Oh, for your dad? Okay. Now, so this patient with this mismatch, you want to remember the mismatch was on ventilation because of atelectasis, and you want to remember how did atelectasis actually happen, and it was from fluid. We have a way of saying Ards in the real world. We say that Ards is a combination of pulmonary edema with sepsis, because one of the number one reasons for Ards is sepsis. Alcoholics can go into Ards just because they have so much fluid collected on their body. So alcoholic, your cirrhosis patient, can go into Ards. We already said the sepsis patient. It has been called acute lung injury instead of just Ards. Acute lung injury, because there's damage to the lung, specifically the alveoli from the pressure of the water. No matter how much oxygen you give this patient, no matter how much oxygen you give this patient, their PaO2 and their pulse ox, but more specifically their pulse ox, which is SpO2, is not going to budge. So no matter how much oxygen you give them, nothing's going to happen. So look at where it says that at. If you look under ABGs, it says decrease PO2, correct? That's your SpO2 for short. It says increased dyspnea, then it says refractory hypoxia, and specifically it says what I just said, which was that there is no improvement in O2 sats. Next to where it says O2 sats, make sure you know that's by definition an SpO2 and an SaO2. Just that little part right there. O2 sats. Said a different way, I could have said no improvement in SpO2 or your SaO2. And it says with an increase in the oxygen. So just nothing happened. I gave you this oxygen, literally nothing happened. Pulse ox didn't change one bit. Usually the patients will fake it for us. You put them on oxygen, they'll go up. They're like, oh, thank you for that. No, not this patient, it's not budging. And that's a classic hallmark. That's how I know Ards from all other shit on the board. Now, when it comes to this patient, you see the signs and symptoms. They're very, very consistent with a respiratory song. I want to give you some extra stuff to add to those symptoms. I would say, if you look at the picture, it tells you one of the symptoms I want you to add, and that would be white lung or white out on the lung x-ray, white out or white lung. This white out or white lung is condensation. Don't forget that word. That word's sort of kind of important. Condensation. So this patient, white lung, condensation. It looks like ground glass on x-ray. I swear the whole lung is white. It's very horrible looking. Very scary. This patient needs a pulmonary artery catheter, so a PAC, which is your Swan-Ganz, a PAC, pulmonary artery catheter, or Swan-Ganz for hemodynamic monitoring. If you look at the causes, you'll see something that says CHELLYS. I want you to know what that means. Anybody know what that means? Anybody seen that before? CHELLYS? Yeah, good enough, baby. Systemic, I want you to write it out. Systemic inflammatory response syndrome. It's very much like sepsis. So systemic inflammatory response syndrome. That MOD means multiple organ dysfunction. That's usually part of all of this, and we see that with sepsis, multiple organ dysfunction. Another reason they may have it is prolonged ventilator. So as soon as a patient gets on a ventilator, some of you might know already that we're trying to wean you off. So the reason why trying to wean you off is because that consistent ventilator setting that you're on is going to give you a very high chance of getting Ards. It's almost like your lungs forget how to breathe, and then because you're not using the muscles, they get weak and they don't remember how to work. So yeah, man, prolonged ventilation is a big reason in the ICU for this guy to get Ards. Pancreatitis is not there, you need to add it. Pancreatitis. And the flu. Because the flu's complication is pneumonia, and the complication of pneumonia is Ards. I'm going to say that again. The complication of the flu is pneumonia. The complication of pneumonia is Ards. So just having the flu can do it. Pancreatitis can do it. Look at the ventilator setting and color the one that says PEEP. Now here's what's really going on with this patient. Because of the alveolar damage, quote, because of the alveolar damage, there is a decreased production of surfactant, quote. Because of the alveolar damage, there is a decreased production of surfactant. Surfactant prevents alveoli from closing and shutting down, so it prevents atelectasis. So with PEEP, the PEEP setting that I made you color on your little picture there, the actual PEEP setting, remember, this means positive end expiratory pressure. Positive end expiratory pressure. How does it differ from all the rest of these? It only gives you pressure at the end of expiration. God bless you. It only gives you pressure at the end of expiration. So the PEEP setting on the ventilator will give you this positive pressure, and it'll just automatically keep the alveoli open instead of allowing them to shut down after you're done breathing out. Okay, so it will literally keep the alveoli open, quote. Because what did that before your PEEP procedure, before your PEEP setting, was surfactant. You don't have any, so you need the PEEP. Now, other issues with this patient that you have to be aware of is when we're treating this patient, we have to remember advanced directives because they're going to die. most of them are going to die. The people who live through Ards are counted on one hand. It's like DIC. Both of these are deadly. It takes 2 years to even recover. 2 years to recover. You can imagine how ridiculous this is. Now, part of the treatment is surfactant. No kidding. So we have PEEP, select all, surfactant. We have steroids as part of our select all. We have diuretics, dobutamine. If you're not writing these, you're crazy. So again, for those of you slow on the uptake today, PEEP, surfactant, steroids, diuretics, dobutamine, even a PPI, which is your proton pump inhibitors, and digoxin. Lovenox will be used to prevent the DVT that's sure to happen since you're not walking. Lovenox. Now, this is going to sound really weird, but it'll make sense when I show you. They cost about $6 million, but the best way to manage this patient is to keep them in prone positioning. Here's why. If I even laid you back in a semi-Fowler's or even a high Fowler's, watch this. Didn't we say that the alveoli collapse because of water? Consider water's heavy. Agree? Wake up, Christy. You got a test to pass. So water is heavy. That's a postprandial hypoglycemia. The water is heavy. So if you tried to breathe against it, you'd be going uphill. If you keep your patient prone, the water will pull away from their chest cavity and the chest expansion can actually take place easier. Now, them damn beds are $6 million a piece. And ain't but 3 hospitals I know got them. But they're very important because even if you don't have the proning bed, they're called a proning bed. Anybody seen a proning bed? Any of you? Even if you don't have the proning bed, as a nurse, you've got so many tubes coming out this person, but you're going to put a pillow underneath the shoulders, a pillow underneath the groin, so that some of these tubes don't get all jacked up. But prone is the best position. You had to know that. So proning the patient. Okay.